Hi, my name is Elise, and I'm a nurse on the OB floor. I wanted to talk to you a little bit about postpartum mood disorders. So I like to think of them on a spectrum from what can be considered most normal to what could be considered most abnormal. So starting off with what's most normal, I think of that as the postpartum baby blues. This is a condition that can affect up to 85% of women, and it starts at childbirth and usually ends around 2 weeks after childbirth, although it may end earlier than that. This is characterized by feeling sad and anxious and crying a lot and not eating as much, not feeling as hungry, some difficulty sleeping, and just some difficulty adjusting to the fact that your new baby was born. So again, very normal. This can be caused by like that massive drop in hormones, that immediate lack of sleep that you start getting right when you have a baby. So we can do a lot to support women through this time period. We want to let them know that this is normal. It's okay to feel sad and different after having had a baby. We want to provide education on things that she needs to be doing with her newborn, lactation support. We should probably assess her support network. Who's there to help her out? Does she have people that can help her? And just talk about the importance of sleep and nutrition, getting outside, exercise when she's ready around the 6-week mark. So the primary nursing intervention for this baby blues, I would say, is education and providing emotional support. And then moving on down that spectrum, so next we're going to talk about some postpartum depression, which I would say is like the heavy version of baby blues. This usually it starts within the first month of the baby's life, so those first 4 weeks postpartum. And so it's different than the baby blues, which end after 2 weeks. This usually starts not at birth, but a little bit later, and then can carry on within the first year of the infant's life. So who's at risk for this? Young moms that have had a baby under the age of 25, people with a personal or family history of mood disorders, people who are unmarried or are not having a good time in their marriage right now, people who've had an unintended pregnancy, or they don't have a lot of education about babies, or maybe they have a lower, they've only completed high school, something like that, a lower level of education. Those that have had a traumatic birth or pregnancy experience, those that abuse substances, and those that may have experienced a stressful life event within the postpartum time period. So how is this different from baby blues? Well, we talked about the time frame. It's also way more intense. So you're getting that anxiousness, that crying, those lack of appetite, the difficulty sleeping, all those symptoms, as well as some very specific symptoms such as irritability, so like violent outbursts, like yelling at a partner, followed by periods of uncontrollable crying, no interest in the baby, thoughts of harming self or baby, and then like not willing to bond with the newborn can be an issue as well. So those are things to look out for with postpartum depression. What can we do as nurses for these mamas? Well, assessing for depression is a big one. So we want to make sure we're using like the Edinburgh Postnatal Depression Scale, or the Postpartum Depression Screening Scale, before discharge, and maybe at the baby's 1 month, 2 month, and 4 month pediatrician visits. Those are good times to assess. We also want to be promoting good sleep for mom. We want to say 4 to 5 hours of sleep a night. That also means counseling mom and her partner or support person on the fact that there might need to be a schedule where partners can sleep in those big chunks of times and the other one takes up feeding and changing during that time to promote that rest. We also want to promote nutrition. Vitamin B12 and folate can be deficiencies that affect the production of serotonin, so we want to promote really balanced nutrition. We want to promote mom getting outside and getting some exercise and just feeling like herself a little bit again. We want to promote partner coping strategies, so just telling dad or the partner or support person that the mom's outbursts may not be directed at them, and how they can set boundaries and help and share the workload that a baby can bring. In more moderate and severe cases, we can work with SSRIs and prescribe mom the antidepressants so she can start feeling like herself again. Okay, moving down the spectrum again, we're going to talk about postpartum anxiety. So this one is kind of on par for me in severity with postpartum depression, but this one is marked more by feelings of like physical anxiety, like increased heart rate and palpitations, obsessing about safety of the baby or the fetus, difficulty focusing on other things, feeling on edge or forgetful, inability to sit still, muscle tension, avoiding certain people or places that bring you anxiety, and being overly cautious in situations that don't really warrant it. So we really want to look out for just kind of like that obsessive anxiety about baby, because that's not normal. Some worry, very normal, part of that baby blues. But again, this one's a little bit different. It's within that year time frame instead of that early 2-week time frame, and it's intense. So we want to look out for that. As far as what we can do for these mamas, we want to promote the use of cognitive behavioral therapy. So talking it out, reframing our thought patterns, questioning those negative thoughts whenever we can. We want to encourage self-care. We want to promote relaxing things such as musical therapy or aromatherapy to help mom feel better, get her outside and exercising when she's ready around the 6-week mark. And ultimately, if those don't work, we can always go back to that medical therapy and help her out with administration of benzodiazepines to control that anxiety. Okay, and then lastly, we've got on the far end of the spectrum, postpartum psychosis. This is a medical emergency. This is a very dangerous postpartum condition to have. It can be caused by, as with all of these, the big hormone drop that happens after birth. Sleep deprivation, always a factor in all of these disorders. Very difficult. Other predisposing factors is having a previous history of postpartum psychosis or being a first-time mom with obstetric complications. It can just be really disorienting. It can be really difficult to process everything. And, like I said, those hormones, sleep deprivation, it's nuts. So, that being said, we really want to look out for with these moms. It starts off kind of like all the other disorders where there's fatigue and there's crying and you're like a little bit emotionally liable, so you're not necessarily having an appropriate reaction all the time, and then it can progress to these delusions, auditory or visual hallucinations, profound confusion, rapid mood swings, and then the really dangerous part is thoughts of suicide or infanticide, or acting on thoughts of suicide or infanticide. So we want to stop that before it begins. We're looking for those delusions, those warning signs that may be coming. So we want to take this really seriously. Again, since this is a medical emergency, this usually requires inpatient care. So mom would be hospitalized, and we'd be making sure that she's getting the emotional support that she needs, as well as the medical support she needs. In many cases, there's antipsychotics prescribed, benzos, mood stabilizers, that mom is getting in order to recover. During this time frame, we also want to slowly reintroduce her back to her baby, and make sure that that bonding process is occurring and that mom can start to cope with the challenges again of having that baby. So can she, change diapers? Can she stay up at night with her kiddo, and get used to the process again and go home safely as soon as possible with a happily bonded baby. So let me know if you have any questions, and we'll see you around.